My name is Beth Vogel. I'm a genetic counselor with the newborn screening program in New York State. This presentation actually was put together as part of our preparation for screening for adrenoleukodystrophy. We got a group of genetic counselors in New York State together on a conference call, and Dr. Raymond joined us, and we talked through some of the practical issues that we expected we could see with families and things to be aware of. Full disclosure that some of these things are not specific to newborn screening for adrenoleukodystrophy. They're things that could come up in a family anyway, but it was important for us to talk about for a couple of reasons. Number one, an X-linked disorder is somewhat new to newborn screening, and we're used to dealing with recessive conditions, so we wanted to talk through some of those considerations. And also because at the time when a family has a newborn child, can be a challenging time to be giving them a lot of information, especially because it's not just about their new baby, but about themselves and their whole family. And we were concerned about what that impact could be and just wanted to make sure we talked about it and we're all aware of the potential issues and had some strategies to deal with those things. So what's the role of genetic counselors in ALD newborn screening? Certainly giving information, teaching about the condition, but also identifying other potential family members. Informed consent for parental testing is very important, that it's done thoroughly with a lot of detail, and we'll go through some of that information, as well as looking for and addressing psychosocial concerns. So why is ALD different? Because it's X-linked and we're used to mostly recessive, as I said, and also because there's a possibility of an adult onset condition. So that brings to light some things for us to think about. So it got many geneticists in the audience, and you're familiar with this, but this is X-linked recessive inheritance. So in this instance, there's a carrier mother. She has 2 X chromosomes, and one of her X chromosomes has a mutation. So she will 50% of her sons have a 50% chance to have adrenoleukodystrophy. Her daughters have a 50% chance to be a carrier, and then likewise she could have an unaffected son or daughter. So what I'd like to do is go through some sample pedigrees. I've got 2 pedigrees and we'll go through different individuals in the family. The assumption for this is that the proband is the first identified family member. So certainly we expect that through newborn screening, we may find a child who already has a sibling who's been identified and is receiving treatment, or a cousin, but for the purpose of this discussion, we're assuming that the child being identified through newborn screening is the first in the family. So let's take a look at this first family, and if we look at our generations, we'll start at the bottom with generation 3. And this individual is the first identified boy through newborn screening in the family. So for this individual, the clinical management of his disease is the most important consideration at that time. And I think Dr. Raymond did a great job explaining some of those monitoring and surveillance that's needed. So the next individual is, there we go, individual 3-3. So that's a female first cousin. So the issue there may be carrier testing in a minor. The parents in the family, when this is brought to light, are very interested to have as much information as they can. They may want carrier testing in this individual, but if she's under 18 and she's not having any issues, there's some concerns about doing that, and usually you don't recommend carrier testing in a minor unless she makes her own decision to have that information. So then let's look at individual 3-4. So again, this is a male first cousin to the proband, and in this case, he also has ALD, and clinical management of his disease is important. One concern that we talked about is that he may be symptomatic and undiagnosed. So while you're meeting with the family about their newborn, they may be realizing that their nephew could also have ALD. Again, not a bad thing that he's identified. In fact, he's a very lucky boy that he was identified, but that could impact the counseling session with that family, that you're also talking to them about other people in their family, and they're sitting there thinking, my nephew's had some ADHD going on, could he have this condition as well? So the next individual is, let's look at 2-2. So this is The mother of the child who is identified through newborn screening, she has to decide whether or not she wants to have carrier testing done. And that has an impact for other members of her family, because if she finds out she's a carrier, then her brother, who's this individual, and her sister also would know that they potentially have a risk for ALD and to have testing. Even if she chooses not to have testing, they still should be informed about it, but her test results could have implications for them. She may also be concerned about life and long-term care insurance. So for an individual with pre-symptomatic disease, they have to think about the possibility that that could cause them difficulty obtaining life insurance or long-term care insurance in the future. In fact, many individuals choose to get more life insurance before they have testing done so that that's not in their medical record at the time. The mother of the first identified child may also have symptoms and not be diagnosed as ALD related. So at the time that you're first talking to them about their newborn, they may be thinking, I've got some issues going on and maybe this is what it is. We've had a few families that we've heard back from our clinicians in New York that the session about the newborn becomes about the whole family. And in fact, a father who became very interested in talking about everyone else in the family and what was going on with them. Not a bad thing, and these things happen no matter how they're identified, but through the lens that we've got a newborn baby in a family who's at a very vulnerable time. This individual also may be experiencing guilt and shame. That again is something you could see in a mother, even if her child's not identified through newborn screening, but something to be aware of. And there may also be some anxiety about explaining the results to other family members. I think Michelle is going to talk more about our experience in New York, but this has been a concern for some families, especially in some cultural situations. Okay, so individual 2-3, so this is a 30-year-old man who's an uncle to the first identified child. He may be either pre-symptomatic or symptomatic and not diagnosed as ALD related. His disease management is very important. Obviously, adrenal consideration is very important and would be life-saving if identified before symptoms. But he may also have some psychosocial concerns with despair, fear, depression, anxiety, as well as the same considerations for a female of difficulty obtaining life and long-term care insurance. We as a group in New York, when we talked as genetic counselors that would be seeing the families, decided that we would only give results to these men in person versus over the phone. So I think a lot of things happen over the phone as part of the course of things that you need to get done to get the results out, but for this situation, we thought that in person was necessary. Okay. So this is a different pedigree. We've moved on to a family who has a female carrier who's the first identified in the family. So the female screens positive baby girl through newborn screening and is identified as a carrier of ALD. The considerations for her is that she may develop symptoms in adulthood and also future reproductive risks of having a son with ALD or daughters who are carriers. For individual 2-1, that individual has a 50% chance to be a carrier, assuming that her mother is in fact a carrier, and her future pregnancy risk for having a son with ALD, that opens the door to prenatal testing options if she in fact is a carrier, as well as her risk to develop symptoms in the future. So then individual 2-2, this is a father of the baby girl who was identified, and the considerations for testing in the father. We have a consent form. We actually do the testing in New York at our lab as part of the process for newborn screening. So we will get the samples for the parents. And we have a consent form for the father that is very detailed and talks about the chance for him to develop symptoms and what this information could mean for him. It's very important that we receive that consent in order to do the testing and that he fully understands. So again, the same issues that we've talked about previously with life and long-term care insurance, disease management, stressing the importance of this, and making sure that if he is in fact diagnosed, that he follows up with neurology and endocrinology. Again, giving the results in person, as well as being aware for potential despair, fear, depression, anger, and anxiety. Again, all of these are things that are common for many genetic conditions, but in this context, we wanted to talk about it in more detail. Okay. So individual 1-2. So this is the grandmother to the female who was identified as a carrier. She could be a symptomatic carrier. She could also experience guilt and shame. And she also could have concerns about life and long-term care insurance. So that's all of we tried to cover all of the different possibilities that you may see in a family. I'm sure there's other things that will come up as we have more experience and work more with the families, but this was put together before we actually started, and I think a lot of the things that we talked about have come to be issues in some of the families. So these things are important to consider if you're thinking about or in the process of implementing ALD in your state. Cultural beliefs and religious beliefs and resistance to disease monitoring definitely can be a consideration. Already, we've had some families that have not wanted to follow up or have had difficulty with talking to their family members about the diagnosis when there's many potential individuals at risk. So I think what I'll do, because I'm going to totally change topics, is give you guys a chance to ask any questions about this, and then I'll move on to talking about some differential diagnoses from the ALD newborn screening. Debbie? Yeah, so that can be a challenge. I think explaining the importance to them, giving them the tools, sometimes giving them a letter that talks about the condition so they don't have to feel a burden of explaining, but there is obviously privacy concerns of going and finding that person and telling them. There's a lot of information about duty to inform out there and what the duty to inform is, and it's discussed at length, but at least in my own experience, you try and work with the family and work through their hesitation.
I'm told we have to talk through the mic, so I'm going to be your MC.
Okay. Yes.
I don't know if this is a question for you. Did New York decide that they would go ahead and do parental testing?
Yeah, so Michelle can certainly answer that too, but the precedent was set that we do parental testing for Krabbe disease. It can be useful for phasing, not so much in a male with ALD because we know where he got his X chromosome from, but it also is to make the process smoother for the families, to help our clinicians. It removes a barrier of having to get additional testing covered by insurance and work through that process. So I think Michelle, do you have anything to add about that?
A lot of times insurance companies won't cover parental testing, and so as part of the service, and this started when we started Krabbe screening, mostly for phasing because the gene is very complex and we can find multiple variants that could come from either parent. We also use it as a quality control. So we get a sample back from baby and both parents, and then we check identity on the baby, so we get kind of that whole family unit. The one thing Beth didn't have up there that I thought was we also could reveal non-paternity as a risk, obviously, when you're looking at dad with a baby girl carrier. But we had that happen once or twice, I think, with Krabbe.
So are you only doing that for parents or for extended family members?
So
I'm going to turn the mic off. No. We do some limited testing, particularly on siblings. So we've always, if we found a baby, sorry, Beth.
No, go ahead.
If we had a baby, say, who we identified and they have older siblings at home that we have specimens for, typically we will test those for them. Very limited cases, we might do some other family members, or it's really a case by case with a health concern, insurance coverage as a public health service.
What are the implications for inheritance when you have a father that is late onset and has the allele mutation, and you also have a mom who is a carrier?
Well, we haven't encountered that yet.
Is it not possible? Is it not possible that a daughter could inherit both affected alleles?
Yeah, and I mean, we talked about Turner syndrome, and in a female, and what would we find, and as being possible, but probably very rare.
But now you're talking about 125,000 times 125,000. So somewhere out there, is a quote, there's going to be a homozygous female. So when you find her, let us know.
So theoretically, it's not an exclusively male type disease.
That's right.
Okay.
I think we figured out Turner syndrome would be more likely than that, right? Because the incident, could happen.
I'll do here, and we'll be back.
How does New York handle the training of the genetic counselors? Because this seems to me to be significantly different than other X-linked recessive diseases.
We started with this discussion. We talked through considerations. As cases have come up and there's a need, we have further discussions and are available as a resource. Dr. Raymond has been available as a great resource, both to talk with our clinicians, counselors, and families. The training was limited to discussing it and bringing the issues on the table, but then as issues come up, we address them one at a time.
This is a question back to testing siblings. As far as testing siblings go, how long would y'all store samples that you can go back and pull samples from that, or cousins, or?
We have samples from 1998. So we've actually used them for several of the other conditions. So and generally the siblings are, going back to early 2000s, mid 2000s for the most part, but we have them back 16 years.
Right, and just to give we have a,
Before you do get consent before you test?
We asked the parents to submit a consent form to us to allow us to do it. And they signed a consent form for this, just like a lab, it's really like a clinical lab test for us.
Neela, wait. So they'll come and see you and the physician who'd order the diagnostic testing, or you would do everything with the counseling, how the disease is managed, you'll give everything, right?
so I'm actually at the newborn screening program. We
I'm
have,
sorry.
yeah, no, that's okay. We have 9 specialty care centers throughout the state, and I think the model in each one would be a little bit different for how they work best with their clinic flow. I think part of our reason for having this discussion is to talk about how important it is that there is a counseling component to their visit, but how they work that out and fit it into their clinic, I think you'd get probably 9 different answers. Yeah.
I will say that we're fortunate to have Beth and Sarah, who are genetic counselors, who came from the clinical setting where they saw the newborn screening referrals, and so now they're helping dole them back out. So it's a good perspective to have them on board.
So when you tell them recurrence risk, are you putting in a caveat that you can't give a full recurrence risk without checking dad if mom's the carrier?
Oh, because dad could also have a mutation.
Likely be
Yeah, so
a
the
late
consent
onset
form
carrier.
does say that the parents are only being tested for the mutation identified in that individual. So the parents don't get full sequencing, they get no mutation analysis. The consent form says, we're only looking for this, the possible outcomes are this, this, or this. Yeah. Again, hopefully we're giving full disclosure, and the consent form includes all of that information.
Remember, we had a de novo case as well, which was useful. We had one case, I think, a de novo case where mom
there's
did
been a
not
couple.
have the mutation of the male child with the mutation.
Yeah, we've had a couple that have been de novo, I think. Michelle will go over those in
I think it was
detail,
the
but-
first one, one of the
Yeah.
first referrals.
Well, in that one, the first one, we
Second
start
one.
looking at it closely, and we started looking at the family and realizing we've had 9 newborn screening samples from boys from this mother over the years. We were very relieved when she was not a carrier, as I'm sure she was too, but big family, so, yeah.
Any other questions for this part? Okay, carry on.
Okay, so both Dr. Raymond and Ann Mosier talked about some of the other paroxysmal disorders during their discussion earlier. My overview will be brief, but I wanted to give you some context for our discussion tomorrow. So today, our goal was for you to learn a little bit about ALD and paroxysmal disorders and the newborn screening tests, so that tomorrow we can start talking about laboratory protocols, diagnostic protocols in more detail. And certainly, these other paroxysmal disorders are an important consideration because you will find them if you're screening for ALD. So the differential diagnoses of an elevated very long-chain fatty acids, our mass spec guru would tell me that we're not screening for elevated very long-chain fatty acids. It's C26LPC, so I'll throw that out there for him. Same differential list. He corrects me on that one. It's not Joe, though he is a mass spec expert. So the first 3 conditions we've heard about in detail from Dr. Raymond and their clinical implications. So we'll start our discussion today with talking about Zellweger spectrum disorders, as well as single enzyme deficiencies of peroxisomal beta oxidation enzymes, and a very brief discussion about CADs. So some of the diagnostic testing that can be done for peroxisomal disorders: very long-chain fatty acids, plasmalogen. Some other peroxisomal markers include plasma phytanic acid, pristanic acid, plasmalogens, pipicolic acid, and bile acids. So all of these are tests which could be done to figure out the diagnosis, in addition to genetic testing. So the Zellweger spectrum disorders, which I will refer to at some points as ZSD, there are 3 phenotypes: Zellweger syndrome, neonatal adrenoleukodystrophy, and infantile Refsum disease. And we'll talk about each one in a little bit of detail, and they're in order of decreasing severity. So Zellweger syndrome is the most severe. The incidence is estimated at 1 in 50,000 to 1 in 100,000, and it's caused by mutations in one of the PEX genes, of which there are several. It presents in the neonatal period with a distinctive facial feature and dysmorphism, a pronounced hypotonia, poor feeding, hepatic dysfunction, seizures, and there can also be bony abnormalities. I think these cases obviously are very sick babies. They're usually in the NICU. In our experience so far, when we have a very elevated C26LPC and a baby who's marked as being in the NICU, it's turned out to be a baby with Zellweger syndrome. So many systems can be involved: the ears, nose, mouth, cardiac, endocrine, GI, hepatic, as well as the severe hypotonia. Treatment is supportive, and I'm delighted to hear there might be some detailed guidance coming out on that in the future. Early identification, although there is no specific treatment, can help with appropriate symptomatic care, as well as with recurrence risk counseling for the family, as well as the diagnostic odyssey that many families may go through to figure out what their child has and what's causing their symptoms. So neonatal adrenoleukodystrophy is less severe than Zellweger syndrome. They can have neonatal or early infantile hypotonia and seizures, a progressive white matter disease, and death in late infancy. So although I'm saying less severe, still a very serious condition. Some places in the literature it says it can mimic spinal muscular atrophy. Infantile Refsum disease, again, is a less severe disorder than the other 2. There's an absence of progressive white matter disease and is extremely variable from severe global delay to moderate learning disorder. Growth failure is also a feature. Most of these children survive infancy, and there are some reports of them reaching adulthood. So those are the Zellweger spectrum disorders. And now we'll talk about the single enzyme deficiency of the peroxisomal beta oxidation enzymes. So I was going to put the pathway up for you of the process that happens in the peroxisome, but I decided I'd leave that for my biochemist colleagues. But in these cases, their peroxisomes are present, but there's a defect in one enzyme that works within the peroxisome. So that's really the difference between the two conditions. For the Zellweger spectrum disorders, it's affecting the global peroxisome versus a single enzyme in these conditions. So 15% of individuals that have a clinical phenotype like Zellweger spectrum disorders and have increased very long-chain fatty acids would have a single enzyme defect. They do not have a mutation in a PEX gene, and the diagnosis is possible through biochemical testing as well as genetic testing. One of the conditions, and although still very rare, more common of the two, D bifunctional protein deficiency, is estimated to occur in 1 in 100,000 individuals, and it's caused by mutations in the HSD17B4 gene. There is no available treatment for this condition. Both an infantile and juvenile form have been described in the literature. So the list of symptoms for the infantile form will look very similar to the Zellweger spectrum disorder. Neonatal hypotonia, seizures, failure to thrive. These are obviously very sick children with many systems involved, and sadly there is death in infancy. The juvenile form, which seems to be very rare, I only found one report of it, is also called type 4 DBP. These individuals had cerebellar ataxia, hearing loss, peripheral neuropathy, and premature ovarian failure. So although very rare, I think with newborn screening we seem to find everything, right? So still a possibility. The other single enzyme defect is acyl-CoA oxidase deficiency. Only 31 patients have been reported with this condition. These individuals can have hypotonia, seizures, developmental delay. They have a regression between 24 and 48 months of age with death in early childhood. There is no treatment available, although there is a single report of stem cell transplant with limited improvement. Although certainly that, with how rare it is, that may be something that's an option for the future. And then CADS, as I mentioned, it's a contiguous deletion syndrome of the ABCD1 gene, which, as we learned today, also causes X-linked adrenoleukodystrophy, as well as the DXS1375E. I'm glad I have the slides for that one, because I did not have that memorized. So the deletion of both of those genes. The clinical symptoms and biochemical results are consistent with Zellweger spectrum disorders, but it's important to identify because the inheritance would be X-linked versus being autosomal recessive. All right, I told you, brief, but that's everything I had to just give you a little taste of what those conditions are like. Certainly there's a lot written about them, and I'm sure we'll continue to learn and talk about them as screening for this condition expands.